I'm Dr. Rachel Beaupre, and welcome to this presentation of the use of sodium glucose cotransporter 2 inhibitors in veterans with a diagnosis of heart failure with reduced ejection fraction. Nearly 5 million Americans are living with congestive heart failure, and it is the leading diagnosis in hospitalized Medicare patients and a very common cause for hospital readmissions. Healthcare costs for treatment of this diagnosis alone are projected to be $53 billion in 2030. Of all the currently available medications, SGLT2 inhibitors are the newest class and have been demonstrated to significantly reduce hospitalizations and cardiovascular outcomes, especially in patients with heart failure with reduced ejection fraction. As of February 2021, there is Class 1 indication based on multiple randomized trials in patients with heart failure with reduced ejection fraction, and it is now part of guideline-directed medical therapy. The VA is in a unique position as SGLT2 inhibitors are on formulary and at our disposal for veterans who meet qualifications for use of this drug. Our objective was to define the status of SGLT2 inhibitor use in veterans diagnosed with heart failure with reduced ejection fraction, to provide educational intervention to cardiologists and primary care providers within the VA system, and reevaluate post-intervention practice patterns and initiation of SGLT2 inhibitors. The main goal is to improve maximization of the use of SGLT2 inhibitors and hopefully demonstrate an impact on future hospital readmissions. We collected records and reviewed the charts of all VA patients with a diagnosis of HFrEF seen at the Detroit VAMC from 2018 to 2022. Demographic information was collected and analyzed for contraindications for the use of SGLT2 inhibitors. Interventional education was performed in April and November of 2021, and individual feedback was given to providers. Post-intervention, we assessed practice patterns to see if there was any improvement in the initiation of SGLT2 inhibitors. Our ultimate goal is to reanalyze this data at 6 months post-intervention and assess for impact of initiation of these medications on hospital readmissions. The results of this project revealed that the use of SGLT2 inhibitors was at 8% prior to intervention, and at 3 months post, it had increased to 11%. Over half of our patient population were non-diabetics, and as expected in the veteran population, most were male. 87% of patients were on beta blockers and 70% were on ACE inhibitors, ARBs, or Entresto as their baseline medical therapy. Interestingly, a good number of patients were at high risk for UTIs, a relative contraindication restricting the use of these medications. The trend of increase in use of SGLT2 inhibitors followed that of VISN-10 and was not significantly different. However, only 14.3% of the patients who were eligible for the use of this medication had been initiated on it. Thus, a significant number of patients that would benefit from this drug are still not on it. A major limiting factor in our population was that 18% of our patients had high risk for urinary tract infections, a relative contraindication to the use of these medications. In conclusion, educational intervention in the Detroit VA system was effective as demonstrated by a 300% increase in SGLT2 inhibitor use in our target population after intervention. The rate of SGLT2 initiation and the number of patients being treated with guideline-directed medical therapy in the Detroit VA is not significantly different from that of VISN-10 or the national VA average. Despite this upward trend in utilization, we suspect the slower rate of initiation may be due to hesitation among providers to use what was initially a diabetic medication in a non-diabetic population. As is seen in our baseline characteristics, the majority of our HFrEF patients do not have diabetes. Given that its expanded Class 1 indications for use in heart failure patients with reduced ejection fraction are relatively new, this may explain some of the lag in adaptation of initiation of this class of medications. Future aggressive education and implementation of quality metrics, we believe, will increase adherence to guideline recommendations for the use of SGLT2 inhibitors in our patient population. Hopefully, at the 6-month follow-up, increased use of these medications will have reduced rehospitalization of patients with HFrEF in our population and help alleviate significant costs associated with readmissions of patients who carry this diagnosis. Thank you.